Hey, sorry. I'm gonna close this door. Okay. All right.
Good evening, everyone. We will let everybody join the session and then we will open it up. Thank you for joining us. We had a little bit of technical difficulties getting on, so we'll just give it a couple more minutes for people to join and then we'll get started. Okay, I'm going to go ahead and get started. So welcome everybody to this evening's webinar to discuss emphysema and Zephyr Endobronchial Valve treatment. I'd like to introduce our speakers for the evening. Dr. Umair Gauhar is the Director of Interventional Pulmonology at the University of Louisville Hospital and also the treating physician for the U of L's Endobronchial Valve program. Dr. Gauhar began the valve program and was part of the Liberate trial, which was submitted to gain FDA approval for the valves, and he's treated over 60 patients. We also have Tommy Richardson with us this evening. Tommy is a patient of Dr. Gauhar's who was treated by Dr. Gauhar with Zephyr Valves initially in 2016 as part of Liberate. We have a large group with us this evening, so all lines will be muted throughout the presentation, but there will be a question and answer session at the end of the webinar. So if you have any questions for Dr. Gauhar or Tommy throughout the webinar, if you go towards the bottom of your screen, there's a Q&A box. So you can submit your questions there, and then Dr. Gauhar and Tommy will get to as many questions as possible at the end of the presentation. So I'd now like to turn it over to Dr. Gauhar to kick us off. Thanks, Dr. Gauhar.
Thank you, Holly, and welcome everyone, everyone who's joining and joining on his or her behalf or on behalf of some loved one. I'm hoping that this will turn out to be a wonderful session that will help everyone understand what this treatment is all about. And hopefully we can help a lot of people. So let's start with the outline of our talk. This is how our talk will flow. We will discuss COPD with a particular emphasis on emphysema. We will discuss how the Zephyr valves work in emphysema. And then we'll move on to discussing what are the particular tests that are done when we are evaluating patients for this particular treatment. I may use the term BLVR, which is a short term for bronchoscopic lung volume reduction, which is the umbrella term under which Zephyr valves are done. We will also discuss on what our patients can expect around the time of the procedure and also after the procedure. And then we will turn our attention to our patient, Ms. Richardson, and she will tell you firsthand her experience before and after the valves, and hopefully we'll have a lively Q&A session at the end. So what is COPD, chronic obstructive pulmonary disease? A lot of our audience may have heard this term. Some of them may have been diagnosed with this term. COPD is actually a large term. It has many different conditions underneath it. But collectively, COPD is a group of chronic progressive lung conditions that are characterized by obstruction to airflow. And I want everyone to focus on the chronic nature of it. This is not something that develops over weeks. It usually develops over years, and the progressive nature of it. So even after the initial inciting agent, whether it was cigarette smoking or something else that started the disease, even when that is taken out of the picture, the disease can still progress in terms of its symptoms. The most common cause of COPD, especially in this part of the world, is cigarette smoking. COPD is not a minor problem. It is a major cause of death and disease all across the world. And according to most recent data from the CDC, about 16 million Americans suffer from COPD of varying degrees. So if we follow patients with COPD, as I mentioned in the previous slide, it is a progressive disease. Um, their lung functions continue to decrease, which leads to worsening of their shortness of breath. And on top of that, COPD can have periodic flare-ups, which are called COPD exacerbations, where the symptoms get worse. Sometimes people can have fever, chills, cough, sputum that leads them to seek medical attention, take time away from work and school, um, and often leads to further insult of lung injury that can lead to further accelerated decline in lung function. So a major part of COPD management is actually decreasing the incidence of these exacerbations. Overall, as you can imagine, someone who's having difficulty in breathing with a progressive declining lung function and periodic flare-ups that require the patient to go to the hospital or clinics, it's all going to affect their life and uh, overall function. In addition to the healthcare or the effects of COPD on the person, on the healthcare givers, there's a huge cost to COPD management. As you can see, the total absenteeism costs were $3.9 billion in 2010, and an estimated 16.4 million days of work lost because of COPD. This is from the CDC. This is a map of the United States that shows how the incidence of COPD is distributed across the country. The darker shades indicate higher incidence. And as you can imagine, the incidence correlates with the rates of cigarette smoking. So we are right here in Kentucky, in Louisville. And as you can see, we are right in the middle of perhaps the highest incidence or highest prevalence of COPD. And wherever there's high prevalence of COPD, there's also going to be high death rates from COPD because of progressive decline in lung function. So in Kentucky, we have very high rates of cigarette smoking, which leads to high rates of COPD and associated morbidity. This is just another graph that shows how the mortality of COPD has been in males and females. This is our overall mortality that has somewhat plateaued, continues to decline in males a little bit, perhaps because of increased awareness about cigarette smoking, increased awareness um, about COPD, better treatments. And then you can see the graph in women as well. So COPD continues to remain a significant problem for the healthcare industry. When we talk about COPD, as I mentioned, it's a big term. And under it, we have many different lung conditions. The two most common that patients and their family members may have heard is emphysema and chronic bronchitis. And then there are several others that we will not cover in this talk. For the purpose of this particular talk, we will focus only on the emphysema kind of COPD, because this is where the Zephyr valves are designed to help. The Zephyr valves are not indicated for the chronic bronchitis kind of COPD. What is emphysema? This is a type of COPD which is characterized by progressive destruction of lung tissue. And as the lung tissue is destroyed, the person has increased shortness of breath. And in addition to it, as a function of destruction of lung tissue, abnormal amounts of air get trapped in the lung, which is called air trapping. So the lungs become bigger than usual. And that puts further stress on the heart, the diaphragms, and all the apparatus that our body has to help her breathe. And this further increases the shortness of breath. So here on this slide, you have a microscopic view of normal lung. So the normal lung has these little air pockets that look like sponge, and it is elastic. So when you breathe in, the lungs expand, and when you breathe out, they shrink. But as lung tissue is destroyed in emphysema, you can see that these air pockets become fairly large, and the extra air is trapped in these air pockets. And when that happens all across the world, all across the lung, in millions of alveoli, the lung overall becomes much larger, and that stretches the diaphragm, the intercostal muscle, which are the breathing muscles between the ribs, and also the ribs, and also puts pressure on the heart, and that is called air trapping. And this is how patients get even more short of breath, sometimes with minimal activity. And this is a particular problem in emphysema, air trapping, where the Zephyr valves are supposed to help. So this is an X-ray, a very classic X-ray of an emphysema patient. We see a lot of black up here. Black is all air in X-rays. So you see a lot of extra air, which is the air trapping. Um, Perhaps patients who are not used to seeing X-rays cannot tell, but the rib spaces are much more wide because they are pulled apart because of the hyperexpansion of the lung. And the diaphragm, normally the diaphragm should be a dome, just like this. It should be a dome upwards, and as patients breathe, the dome flattens. But in this case, the diaphragms are completely flattened because there's so much extra air trapped in the lungs that it's just pushing the diaphragms down. And the heart is also looking very long and tubular because the heart sits on the diaphragm and the diaphragms are pulled down. So it almost looks like it's hanging in the air. So this is an example of emphysema with destruction of lung tissue and extreme hyperinflation or air trapping with its effects on surrounding structures. And this is a CT scan of a patient with emphysema. As you can see over here, this is the right lung and the heart and the airways in the middle. This is the left lung. These dots and lines are usual normal structures in the lung. As you can see, this part of the lung, there's a lot more black here, which is all air, and the normal structures of the lung cannot be seen. So there's severe emphysema, at least in the upper part of the lung. And as a function of hyperinflation, like I mentioned, when extra air is trapped in the lung, it is not going to help the structures that help us breathe, the diaphragm, the ribs, the breathing muscles. And that by itself can increase the mortality, the risk of dying. And this graph down here, as it's falling very sharply, indicates that if I take patients who have the same degree of emphysema in terms of numbers, but some of them have higher air trapping and some have less air trapping. Those who have higher air trapping will actually do worse and live shorter, even if everything else was kept the same. So air trapping is not just a problem that causes shortness of breath and makes your x-rays and CAT scans look different. It actually affects your lifespan as well. Many of our patients, perhaps they're listening to this webinar, they may actually relate to this slide a lot better than some of us. They live with these symptoms, this condition on a day-to-day basis, and so they know exactly what this feels like. As the lung tissue is destroyed, you develop more shortness of breath. As function of destruction of lung tissue, you develop hyperinflation, air trapping, as we saw on those x-rays, which leads to decreased activity. When you don't exercise much, you become deconditioned, your muscles and bones start to become weak, which makes it even more difficult to stay active. And so you get trapped in this downward spiral where your breathing difficulties are making you inactive, and your inactivity is increasing your breathing difficulty. So it gets really difficult for our patients to get out of this downward spiral. And if you don't move around, obviously you become more prone to developing other problems, not specifically related to lungs, but increased risk of infections, cardiac disease, falls, all those things can come into play as you lose your strength. So COPD, we often think of COPD as a lung condition, and yes, it is a lung condition, but there's good amount of evidence now that COPD has systemic effects. It affects many other parts in the body, really a top to bottom kind of a disease that affects your mind and muscles and metabolism and nutrition. So it is a significant condition or problem to deal with. So how do we treat COPD? Well, we have many different types of inhalers on the market, and these inhalers generally have two kinds of medicines. One is a kind of medicine called a bronchodilator, which helps increase the opening of your bronchial tubes, which helps you breathe. And that is the main way that COPD or emphysema is treated. And oftentimes these inhalers also have an inhaled steroid, and the steroid part helps the inflammation that can set up in the lungs because of exposure to cigarette smoking. And depending on the symptoms and the severity of COPD, patients may require one medicine or the other, but as the disease progresses, almost always they end up on the bronchodilators as well as the inhaled steroids. Pulmonary rehabilitation, which is usually performed on outpatient basis, is a structured exercise program specifically designed for people who are having shortness of breath from pulmonary or cardiac disease. It is a very important part of COPD management, and we will discuss briefly some of the highlights of pulmonary rehabilitation. So that's another important part that helps improve exercise endurance on top of our medical therapy. Before the bronchoscopic lung volume reduction, the endobronchial valves that we will be talking about, there was really no other option after medical management and pulmonary rehabilitation. As we discussed in the initial slide, this is a progressive disease, and as the disease progresses, patients often become severely short of breath and deconditioned, and then the only options that were left were either surgery, which is lung volume reduction surgery, where the thoracic surgeon, the chest surgeon has to go in and remove the diseased parts of the lung, or lung transplantation. And both of these are fairly major undertakings with significant side effects. And obviously, these patients are already on the weaker spectrum of their health. Their lungs are not in the best shape, they're deconditioned. So going through such surgery is no small task. So these were the options that were available before the Zephyr valves came into play, and we will discuss where exactly in this treatment spectrum are they used. A few words about pulmonary rehabilitation. This is an exercise program usually available in any major hospital that has a physical therapy department. What it does, it improves your exercise endurance, improves your dyspnea, your health status, also reduces hospitalizations from COPD exacerbations, and reduces symptoms of anxiety and depression. One thing that I want my audience to understand is that pulmonary rehabilitation does not improve your oxygen levels. It does not improve your numbers on the breathing test. It does not somehow cure or reverse your emphysema, but it allows you to do more with the lung disease that you have. So with that said, we will introduce the idea of Zephyr valves. Zephyr valves are now FDA approved. And these are small valves, just to give you an idea, they're about the same size as a fingernail of an average person. They can be placed bronchoscopically into the diseased part of the lung. And what they are a one-way valve. So what they do is they allow air to get out of that diseased, hyperinflated, air-trapped lung, but they don't allow air to go back in. So over time, that part of the lung deflates, gets smaller in size, and the process, the entire lung shrinks to something closer to normal, which improves the harmful effects of air trapping, and the diaphragms get back to more or less a normal position. So where do Zephyr valves come in this treatment spectrum? They come right in the middle. So like I said before, the Zephyr valves or the bronchoscopic lung volume reduction, we had no choice but to transition patients who are being managed on pulmonary rehab and medical management straight to fairly invasive, high-risk surgery. But now we have an option which is obviously more advanced than the medical management, but much less risky, much less invasive than the more advanced surgery. And what's more, it is a reversible process. So if we place valves and for some reason they don't work or patients have side effects from them, we can remove them without much difficulty, and things go back to where they were before placing the valves. So Zephyr valves in our program, they're usually considered after patients have been compliant with their medications, they have quit smoking, they've gone through pulmonary rehab, but they continue to experience poor quality of life. So I have a small video here, which I will try to mute so I can explain.
The Zephyr Endobronchial Valve.
So this is what a Zephyr valve looks like when it's placed in the lung and it's opened. Like I said, it can be placed bronchoscopically, and we will briefly discuss how the valves are placed. So the bronchoscope is a flexible tube that has a light camera. At the end, some of you may have seen gastroenterologists doing endoscopy for stomach and esophagus, or colonoscopy, essentially similar kind of instrument, but it's designed to go in the lung. And once we go in the lung, we use a catheter that has the valve loaded, and we place these valves in the bronchial tubes, and they act as one-way valves. They act as a gate to not allow air to get back into that lobe and allow all the extra air to get back out. And over time, the lung, as you can see, is deflated and gets back to something closer to normal. And that's generally how I explain the valves to the patients. Once the valves are placed, they are designed to stay in as long as they are working and as long as patients are not having any problems. They are, patients can live with them and continue their activity, without much difficulty. Once the valves are placed, this is a picture of a valve after it has been placed. You see this little duckbill mouth, so it opens to allow extra air to get out of that lobe, and then it closes to prevent air from going back in. And once that lobe is deflated, the valves can stay permanently closed. But this is generally what we like to see once we have placed valves. This is a well-placed, well-positioned valve that seems to be working well. This is one of the patients that we treated, just to give you an idea of how the valves will work and what your x-ray will look like. So this is an x-ray before valves were placed. So a lot of black here, which is all extra air that's trapped. Diaphragms are pushed flat. Heart is long and tubular. So classic emphysema. This patient had valves placed in the upper lobe, right upper lobe. So as the valves are placed, the right upper lobe will deflate. As you can see, the right lung immediately afterwards has shrunk. The diaphragm is starting to become more convex, almost like a dome. And then over the course of few days, that change continues until the upper lobe is completely deflated and now is completely devoid of air. So it looks like tissue because there's no air there. And the diaphragm on that side has become more convex as opposed to the untreated side, which is still flattened. So the movement and the appropriate position of the diaphragm is actually a very important aspect of treatment of bronchoscopic lung volume reduction, because your diaphragm is the most important part of your body that helps you breathe. When it's not in appropriate position, as in this first X-ray, it's at a mechanical disadvantage. It cannot do its function even if it's nice and strong. So we like to see this kind of a shape of the diaphragm after placing valves. This is some scientific data about the valves, and I'm not going to spend too much time on this, but this is just to show that the endobronchial valves is not a new idea. There are multiple studies that have been done to show the efficacy and the safety of these valves. So there was the Stelvio study, Impact, Transform, and the most recent Liberate study, which is where the valves were approved by FDA. They show improvement in lung function, exercise capacity, and quality of life. So this intervention has gone through significant testing and has been now approved and now has been in clinical practice for more than 2 years. And what we like to see is the reversal of all the ill effects of COPD. So once the lobe is occluded, there's less air trapping, which improves lung function, decreases shortness of breath, improves quality of life, and overall health status. And so this is what we like to see in our patients. And I will not touch more on this because we have Ms. Richardson and she can tell you a lot more about this slide. What can you expect during the procedure? So the procedures in our facility are done under anesthesia. You will be completely asleep, and the average procedure is about 60 minutes or less. Once you get the valves, you'll have to stay in the hospital for 3 nights, and that's an absolute must because we have to watch for complications. And then once you're discharged, then we will arrange follow-up with appropriate testing afterwards. As far as complications and risks are concerned, anytime we do anything to the lungs, especially if the lungs are already struggling, there's risk of bleeding, there's a risk of infection like bronchitis, pneumonia, there's a risk of damage to the lung, there's a risk of COPD flare-up. All these are considered, fairly routine, and many of our patients, before they even get to us for valves, have been through most of these. So these are easily treated with antibiotics and steroids. The one complication that we need to talk about and know about and accept while we're proceeding towards valves is pneumothorax, which is a collapse of the lung or puncture of the lung. The risk of that is about 25%, and it generally happens on the same side where the valves are placed. The risk is highest within the first 3 days, and that is really the biggest reason why patients are placed or put in the hospital afterwards and have to go through multiple x-rays. Even if it happens, it's a treatable condition, but it can prolong hospitalization. So anyone who's interested in being evaluated or eventually having the valves has to understand the 25% risk of pneumothorax. Few things that I want our audience to understand is that bronchoscopic lung volume reduction with Zephyr valves is only one of the many treatments for COPD. Once you get that treatment, does not mean that your emphysema is cured, that you can go back to smoking, or you may not need oxygen, or you don't need to use your medications anymore. It adds on to everything else. So you have to continue to do your part to help the valves provide that extra benefit. The patients who are referred to us for valves will have to go through testing. And the reason for those tests, the way I explain to the patient is, we have to answer two questions. Number one, is this procedure safe for you? Your safety comes first. And number two, is it going to benefit you? Are the valves even going to help your condition? Not every emphysema patient will benefit from the valve. So the testing that is done is designed to answer these two questions. And generally the tests that are required is pulmonary function test, a 6-minute walk test, arterial blood gas, that's the little stick near the wrist, an echocardiogram, an ultrasound of your heart, a CT scan of your chest, a perfusion scan, which is a scan that looks for blood supply to different parts of your lungs, and some blood work that's mentioned at the end. And the minimum we are expecting is that your residual volume, which is a measure on your breathing test that tells us how much extra air is trapped in your lungs, should be 150% or more. 120% or less is normal. So there has to be enough air trapped for us to go and fix the problem. If the problem is not there, or it's not really that bad, then putting you through a procedure that's designed to fix the problem may not even help your condition. Also, you have to have realistic expectations. Like I said, this does not cure your emphysema, but it improves your dyspnea, your shortness of breath. So you need to have realistic expectations, and you have to comply with medical therapy and the follow-up. So many of our patients come to us, and after testing for one reason or the other, they are told that they are not a good candidate for valves. And that often disappoints them, and they sometimes can't understand why that is the case. I've listed some of the common reasons why some of our patients will not qualify for valves. Either their disease is so advanced, their oxygen levels are so low, they're needing so much oxygen, or their carbon dioxide level is so high that putting them under anesthesia and going in their lungs is just unsafe. Or they have cardiac disease, or they have obesity, or their functional status is so poor that after the procedure, they will not be able to walk much, and hence will be at risk for having pneumonia. Or they're still smoking. We want our patients to quit more than 6 months or more before being evaluated. Or they don't have emphysema, but they may have other lung conditions like scarring of the lung, or nodules in their lungs, or something that looks like cancer or could turn into cancer. Or they have other kinds of emphysema which actually don't respond to valves and may actually get worse with valves. And then there's something more specific to Zephyr valve, which is fissure completeness scores and destruction scores, which we will talk about. These two scores come out of this report, which is called the Stratix Report, and you will hear this word quite a lot. This is a report that comes out when we put your CT scan through a computer software. And this is perhaps the most important piece of information before we decide to go ahead with valves. For the valves to work, the valves will need to completely block entry into that lobe so that no air can get in. But in many cases, especially in cases with emphysema where lung tissue is destroyed, abnormal openings can develop between different parts of the lung. So say if this is the left upper lobe and the left lower lobe, and this is the fissure or the boundary between the two, we want this to be completely sealed. So if I was to put valves in the left upper lobe, no air can get in from behind the valves. And so this row right up here, the fissure completeness, tells us what is the chance of this boundary or these boundaries between different lobes being completely sealed off. Because if they're not, then putting valves will not seal off that lobe. And I generally explain to the patients that if I was to shut a room so that no one could get in, if there was only one entry to the room, a door I could lock, then it's easy for me to lock that room. But if there are windows in the wall, then I can't really help. So if someone has low fissure scores, less than 80%, then the chance that they have these openings are too high. And then the part of the lung that we're going to be deflating, where the valves will be placed, and hence the lobe will be taken out of commission, it needs to have enough destruction that it should not be a functioning part of the lung. And these are the numbers that tell us how much destruction you have. And this is the bottom part is the part that tells us how much extra air is trapped. So the ideal situation will be where there is complete fissure, so there's no leakage of air between the two lobes, where there's a lot of destruction of that lobe, so that lobe is not really working, and it has a lot of extra air trapped. So that's what we like to see. And sometimes one or the other number is not where we want it to be. And so either the safety of the procedure is compromised or the benefit is low. And that's why patients do not get valves. This is just another way to show the collateral ventilation, which is a term used for abnormal opening between different lobes. So if you have connections between two lobes, that's called a collateral ventilation or a CV positive condition. So being a positive here is not a good thing. It means you do not get valves. And if you have a CV negative situation, meaning the lobes are completely separated so they don't communicate, well, that's the kind of situation where we would go ahead and put valves in. And we actually check it with an instrument called Chartis. This is something that we do when you actually go and get the valve. So before we even put the valve, we confirm that CV status, the collateral ventilation status, by putting a balloon into that part of the lung. And this balloon helps us know if the Chartis, the Stratix report is accurate. And this is the most accurate way of telling whether you are CV positive or negative. This is the kind of trend we want to see, where there's decrease in airflow. But if the airflow continues on the monitor, it means air is leaking behind the balloon and we are unable to seal it. What can you expect after we get the valve? This is the study, Liberate study. So improvement in your breathing tests and improvement in your the validated scores that are used to check your dyspnea, to check your shortness of breath. And then about 84% of the patients who got the valves actually had significant decrease in their lung volume or air trapping. And then even after a year after the valves, patients continue to have improvement in their shortness of breath, activity, and psychosocial status. This is a study that was done by Dr. Dransfield at University of Alabama, where they've followed these patients for 12 months afterwards, and they continue to have improvement. And this is just another way to show that patients who did not get the valves, who got the standard of care, had higher symptoms than patients who actually got the valves. So based on all the available information, patients who respond to valves will continue to show improvement in all areas that are important to not just the physicians, but particularly patients and their families. And these are just pictures that our patient, Ms. Richardson, has sent us. I will not talk much here, and I will let her explain what we are looking at. And her words will be a lot more authentic than whatever I've said.
Well, hi, I'm glad to be here. As you guys know, COPD is horrible. I remember when I first got really sick, I would have flare-ups so bad that I would think, I need to call an ambulance, but there's no way I can walk to the door if they come. So I know what everybody's going through. And I found myself on the transplant list waiting for a double lung transplant. And luckily, my doctor, one of the lung transplant doctors, suggested this trial. He said that they were doing it, and he was looking at my numbers and stuff. And he said, I really think that this is something that could help you. And I said, well, all right. So he connected me with the people doing the trial. And I went and I got valves, and I got 3 in my left lung first. And it was so easy and so pain-free that when I woke up, I had to ask him if I got them because I wasn't even sure. I couldn't even tell. Some people said that you get a sore throat or something, but I didn't. And immediately, not that it took me about a month after the valves that I started feeling better, and it just seemed to get better and better. But I wanted more. Of course, you know, everybody, we always want to get better. And I was on disability. I couldn't even walk down the hall before the valves. It was terrible. So I went ahead, but I had to wait for them to get FDA approved. And then when that happened, I had to wait until the insurance all jumped on board. So I was able to get the second lung done. And that's when I really, really noticed a huge difference. As you can see, I'm in a pool. I could never do that with my oxygen tank, right? Before, you know, you're always lugging that thing around. I can carry a purse now. I used to always have to drag that oxygen around. I was in a wheelchair before I got the valves because I couldn't walk any distances from the garage to the doctor's office. It would have killed me. So it's just made such a difference in my life. I'm able to go out and do things, do my own housework, grocery shop. It's just changed my life completely. I mean, 100%. It's not a cure. I still have to use my oxygen when I exercise. The doctor talked about rehab, and I did that for years. They require it for transplant anyway, but I still do the exercises every day at home that I did in rehab because I know they work. And I know that helps out a lot. And there's mornings when you get up and you're like, oh man, I don't feel like doing it. But you know that you have to put in the work. And I don't want to go back to the way I was. It's just been a godsend for me. On the second lung, I even had the lung collapse, like they said could happen. And the staff was amazing. They knew the minute I knew, and they were on it. And it wasn't that bad. I'm kind of glad in a way that it happened because I can share with other people that if that's the worst that's going to happen, it's worth it because it really wasn't that bad. And I wasn't even afraid because they were all on it. And I knew I didn't have to worry about it. They were taking care of it. It's just been the best thing to come along for me, and I just know it's going to help so many people. I'm just so excited that it's available.
Wonderful. So Holly, do we have any questions, or can
we have a couple questions that have come through. So that actually concludes the presentation. So again, if you have any questions for Tommy or for Dr. Gauhar, there's the Q&A box at the bottom of the presentation called Q&A. So if you click on that and you have a question, you can submit that there. So we have a question. Will this be available for others that have missed the presentation?
Yes, the presentation will be available. It's recorded and should be available.
Yes. Yeah, so, and at the end in a couple of slides, we will actually display the phone number for the Advanced COPD Clinic. Erica Heischman is the coordinator for the valve program. So we'll put her number there. So if you'd like the link to the recording, you can reach out to her and also for any questions or additional information. We have another question. Am I correct that the air trapping increases CO2 production because the air cannot get out, causing cognitive decline? So being able to decrease the trapped air would improve the situation. And they give an example. Their parent is currently on NIV 12 plus hours a day and still battling CO2 increase.
Yeah, I guess it's a good and intelligent question. Yes and no. So air trapping happens as a result of destruction of lung tissue, and as you breathe out, the airways kind of collapse and don't let air exit. Having said that, not every patient with air trapping has high CO2. High CO2 is generally a function of advancement or worsening of your emphysema. Um, and generally, as I had mentioned in one of the slides, when the CO2 level is high, more than 55 is generally what we look at, then the lung tissue is destroyed to the point where, number one, putting you through anesthesia may actually be harmful. Number two, um, the valves may not actually help because the condition has progressed so much. So if patients are at the point where they are needing NIV or other devices to keep their CO2 low, it's not that that is by itself a rule out, but we will have to look at those patients very carefully, primarily to make sure that it's safe for them to go through the procedure and also to make sure that it's beneficial. So yes, the CO2 rising can certainly affect your level of awakeness, can affect your cognitive abilities. Um, but to say that that can be reversed with just the valves, most likely not.
Okay, next question is, do I understand that only one lobe is done at a time?
Yes. As a general rule in the body, whether we're talking about kidneys or eyes or lungs, um, it's because every time we do anything to the body, whether it's from the outside or the inside, we have three main, things to worry about: bleeding, infection, and damage to the body. So obviously you don't want to cause those problems on both sides. So we generally do one side, and then if patients do well and they're benefiting from it, then we consider doing it on the other side. Having said that, I do have to mention that many patients with emphysema do not have any appropriate targets on the other side because there are the fissure completeness scores are low, or there are other reasons. They have scar tissue in that lung. So there may be situations where the other lung may not be a good target. That Stratix report that I showed actually helps us make three important decisions. Number one is safety of the procedure. Number two, whether the patient will benefit from the valves. And number three is which lung and which lobe of which lung is going to take the valve. So that's decided on a case-to-case basis. Ms. Richardson obviously, benefited tremendously with bilateral treatment, and we always hope for it, but it's not always possible for each patient. The beneficial effects of Zephyr valves can be achieved even when you treat one lung. So I want my audience to understand that just because there's no other target on the other side does not mean that you will not benefit from this treatment. In fact, most patients all across the country get only one side treated.
Okay, next question. Do you have to be a resident in Kentucky?
No, not really. We have treated patients from Indiana, Tennessee. I think we even have one from Texas. So no, if you can come here, we can treat you.
Okay, how long do the procedure benefits last?
Very good question. We have Miss Richardson sitting right here. I mean, she can tell you it lasts a long time. This is decided, I guess, on a case-to-case basis. We have patients who have benefited for months and for years. Yes, there are certain patients whose benefit is very short. In a few months, the benefit is gone. Having said that, oftentimes when patients have an acute decline in their function after the valves had improved their function, we often have to look at whether they have developed um, any leakage from the valves, any scar tissue around the valves. Has the valve moved with their coughing or breathing? Has their emphysema progressed? Are they still using their medicine? So there could be many reasons why the benefit that you had has decreased or gone away. And there are ways to fix those problems. So sometimes we have to go back in many months later and If there's scar tissue there, we can easily remove it. If a valve is not functioning well, we can remove it and replace it. So though there are ways to keep the benefit going.
Okay, next question. If a patient has both chronic bronchitis and emphysema, do they qualify for valves?
Good question. I like the question. There's some intelligent people here, huh? So the answer is that just because you have a diagnosis of chronic bronchitis does not rule out the possibility of valves. We will have to look at it carefully to make sure which one of these conditions is the main problem, because the valves are only designed to treat air trapping in emphysema. In chronic bronchitis, the condition is very different. By putting valves, sometimes you can make things worse by increasing the risk of infection and mucus. So patients can still qualify for valve, but we'll have to look at them carefully with testing and make sure that it's actually emphysema, which is the predominant disease.
Okay, so we have a question about lung nodules, and does that rule a person out? And also, how long after having a pleurax taken out should you wait?
Lung nodules. So lung nodules are a very common problem, especially in this part of the country, not just because of smoking, but also because of histoplasma fungus that's all over this part of the country. Having a lung nodule by itself does not rule out the possibility of emphysema. But we do have to make sure that the lung nodule is not concerning for a malignant condition or a pre-malignant condition, and that appropriate testing and workup has been done to rule out those possibilities. And the pleurax catheter, that's a very unique situation. I don't think there are that many patients that we have seen who had pleurax catheters. It all depends on why you had a pleurax catheter. That will be the first question that I would like to ask. A lot of times pleurax catheters are done for malignant pleural effusions, and if that is the case, valves is probably not a good idea. But if it was done for a benign condition, then certainly we can look at the patient, and if the pleurax catheter has been removed, within a week or two, we can certainly evaluate you. The only concern that we will have is that oftentimes after removing pleurax catheters, there's pleurodesis, which is scar tissue forming between the two linings, the lining of the lung and the lining of your chest wall, and oftentimes the lung gets stuck. So even if the valves are trying to deflate that lobe, your lung may not go down because it's stuck to the chest wall. So that's something that I would worry about. It doesn't always happen, but these are things that we'll have to look into.
Okay, we have several questions around insurance, if you want to just touch high level on coverage and what that looks like.
So this is an FDA approved therapy. We've been doing it for more than 2 years. Most insurance plans now cover it. Sometimes we do have to make an appeal to your insurance, and that generally is well received by the insurance companies. So I guess that's all I can say. That if you're interested in it, don't think that should keep you away. There's certainly ways that we can appeal to your insurance and make things happen.
Okay, next question. How long does the process take per lung before you could do the second procedure if things go well?
There's no right or wrong here. I don't think, all across the country, nobody has come up with a fixed timeline. I generally look at the patient, because at the end of the day, it's not about looking at what some other patient did or went through. It's about what the patient sitting right in front of me is going through. Generally within 3 to 6 months, if they're doing well, not having any problem, that they definitely have a benefit from the valve, we can consider treating the other side if there are appropriate targets. But I probably would not treat someone within the first 6 months, just to make sure that they don't have any problems on both sides.
Next question is, does barrel chest reduce?
It will not. barrel chest is not just because of your lungs hyperinflated, you know, the position of the ribs goes into it. So the deflation of your lung is not going to be so significant that it will be perceived from the outside. Having said that, you know, reduction in barrel chest by itself is not something that makes or breaks the issue. And the main reason why you will be short of breath is because your diaphragms are not working well because they're pushed down. And so if we can fix those problems, you will still have the benefits from it.
Next question is, if you already have scar tissue in your lungs, does that disqualify you?
Depends on the extent and nature of scar tissue. If the scar tissue is very localized and we are absolutely sure that there's no malignancy, no infection in there, then no, it does not rule it out, but it has to be evaluated. Again, for the purpose of safety and to determine whether you can actually benefit. So again, that's why we do the CAT scans, to make sure that the scar tissue is not extensive. Sometimes patients have pulmonary fibrosis, which is an extensive scarring condition of the lung, also seen in smokers, and those patients will not benefit from valves. So if you have been diagnosed with some kind or some amount of scar tissue, don't think that that's a deal breaker.
Next question is, how long on average is the process to determine eligibility if no pulmonary rehab has been initiated yet?
Good question. So we like to do this, in a sequential manner. So you come and see us. Most of the time, you've already had pulmonary function tests, maybe 6-minute walk test. A lot of the tests that I mentioned, echocardiogram, CT scan, arterial blood gas, they can be done within weeks. And then we like our patients to go through a few sessions of pulmonary rehab and then get the valve procedure done somewhere in between so they can continue the rest of the rehab afterwards. So, I mean, I can say probably about 4 to 6 weeks is generally a reasonable guideline or reasonable time window.
Okay, next question is, how does one go about getting a review or appointment for testing?
Well, you have, I think on the slide, you have Erica's number. Erica is our coordinator for valves, and you can call that number and you can say you're interested in being evaluated. She will get your records from your doctor and we'll get you in. Unless there is a very obvious reason not to think about valves, we'll be happy to see you.
Next question, does this benefit asthma with severe COPD?
Not really. Asthma is a very different condition, and in asthma, generally you have reactive airways, in a way, twitchy airways, and so the valves are not really designed to deal with that problem. In fact, putting foreign bodies, which is what valves are, in lungs that are reactive can actually make things worse. So no, if you have asthma or asthma is a predominant problem in your lung condition, then the valves are not a good choice for you.
Okay, we have a few more questions. Does procedure usually result in a reduced need for supplemental oxygen?
Good question. Not always. Your oxygen needs are generally a reflection of how severe your emphysema is, or in other words, how much your lung tissue is destroyed. The valves are not designed to regrow your lung. They're basically designed to tackle one specific problem that you get with emphysema, which is air trapping. So if you get reduction in your oxygen needs, that's a bonus. And now we do see it in patients, but don't always expect it.
Okay, next question. Are you including valve patients in lung cancer screening CT program?
Valve patients in lung cancer screening, meaning can they continue lung cancer screening CTs afterwards?
That one we might need some further clarification on if you
Yeah.
want to type again in the chat, or that's something, again, you can reach out to Erica for specific questions and we can get you those answers.
I can answer it, I guess, the way I understand. I guess if they're asking whether after getting valves, you can continue to have lung cancer screening CTs. Yes, you can. That should not affect your eligibility for lung cancer screening. Having said that, if you get valves and there's deflation of that particular lobe, that lobe is going to look very different on the CT scan. It's going to be completely devoid of air, so it will look completely opaque. And so if there is a chance of any cancer or infection in there, it may not show up on your CT scans. So the lung cancer screening CT afterwards will be a good way to track the rest of your lung tissue, but for that particular treated lobe, it may not be helpful. That's actually one of the big reasons why if somebody has lung nodules or something that looks like could be malignant, has to go through very careful workup and screening before getting valves to avoid that particular problem.
Okay, we're running close on time, so we will take the last two questions. What kind of other things are coming out or are being studied for COPD?
So there are other trials going on for COPD, and they're looking at, obviously there are other medications, but there are bronchoscopic trials looking at treating COPD in different ways, such as affecting the nerves that go to the lungs. Those nerves are involved in the way your bronchial tubes work. And then there are other trials that are out there to treat mucus production in people who have chronic bronchitis kind of COPD and have a lot of cough and mucus. So those are trials that are out there. They're looking for patients, and COPD, like I mentioned, is a major burden on patients, their caregivers, and the healthcare industry. So there are always new ideas, coming out.
Okay, our last question. If not on oxygen yet, and you get this procedure, could it keep you off of oxygen?
Yes and no. Like I said, the need for oxygen is mainly because of the destruction of lung tissue from emphysema. And emphysema can be, and it's actually a progressive condition. So as your condition progresses, if it does, if you start smoking again, you're not taking medications as prescribed, if your condition progresses, you can need oxygen down the road. The valves themselves should not make you use oxygen. Now, early on, as your lungs are adjusting to the valves, your oxygen requirements could go up and you may require some extra oxygen early on, but generally, they're designed to help you do more, improve your shortness of breath and quality of life. The oxygen part, like I said, if it improves that, that's a bonus, but that's mainly because of the destruction of lung tissue, which the valves are not going to reverse.
Thank you, Dr. Gauhar. That concludes our webinar for the evening. I will leave this slide up. Again, if you have any further questions or want additional information on Zephyr treatment, you can reach out to the valve coordinator at the number on the screen. I will turn it back over to Dr. Gauhar for any closing thoughts.
Okay, well, thank you very much, everybody, for participating. I think the questions were amazing. There's some highly motivated and intelligent people online, which is what I want. At the end of the day, your life, your health is in your hands, and we are here to help you. And this is really teamwork. I mean, we do our part, we try to help you, and at the end of the day, you're gonna have to take care of your life and your health, give up smoking, take your medications, get your vaccinations, and we are here to help you, and hopefully we'll have a brighter future with COPD coming up. Okay, Ms. Richardson, any last thoughts?
Just everybody call. It's amazing. I promise.
All right, wonderful. All right, I think that we'll end it here, right?
Yes, thank you everyone again for joining, and have a great evening.
All right, thank you too.